Hi, I'm Dr. Gerard Lemongello, and I am doing this presentation for Dental XP. My presentation today is going to be on predictable implant aesthetics utilizing a custom fabricated provisional, a custom fabricated provisional abutment, and a custom fabricated impression coping, all to create beautiful, natural, lifelike aesthetics with implants. Implants has been a journey. You know, it's been a short and long journey. There was a time when, with implants, our whole purpose was to get osseointegration and to provide a predictable way to restore a missing tooth. Today, the journey is different. Today, the journey is all about creating beautiful aesthetics, beautiful teeth that mimic nature in such a way that we can't tell the difference between what's real and what's not. So, creating the illusion with implants is one of the objectives. And just like we have this person, this artist, who's created the illusion by painting on the sidewalk something that's not real, we want to try to achieve the same thing with implant aesthetics. It's creating an illusion, and creating that illusion starts with the provisional. Implants have revolutionized the way we treat anterior missing teeth. The days of having to cut down teeth or modify anterior teeth to create fixed bridge work or removable prosthetics are long gone. Now we have the ability to create implants that can replace a missing tooth in a natural way without involving or destroying any of the adjacent natural dentition. We know dental implants have excellent success rates and have advantages over fixed and removable alternatives for tooth replacement. Dental implants are routinely used to replace missing teeth with predictable lifelike aesthetics, often challenging the ability to tell which is the tooth and which is an implant. Implant restorations do, however, present some challenges depending upon the type of osseous defects. Whether it's a Class 1, Class 2, or 3 defect, the challenges can be very different. If we classify our osseous defects, we usually do so into 3 types. We have a Type 1 site, which is a situation like this where we have no real osseous defect. Once the deciduous tooth is removed, there's a pretty good amount of osseous tissue remains, and implant restoration is relatively simple. In a Type 2 site, we have not only the loss of the tooth, but we also have a labial defect or a palatal defect where the bone is gone, but fortunately the interproximal bone remains. And in a Type 3 type, we have the interproximal and vertical defect, which presents a much greater challenge, now having to decide how we're going to rebuild the osseous architecture as well as the soft tissue architecture to create the aesthetics that we need. Preserving gingival and osseous architecture can be difficult in the Type 2s and Type 3 defects, and they would have to be handled very differently. And this is where we rely on the skills of our surgeons to give us the framework in which to work from to create the aesthetics with implants. The framework for the development of a healthy aesthetic soft tissue is the osseous tissue. We need the bony architecture in order to support our soft tissue. So the soft tissue contours are dependent on the supporting hard tissue structures. Preservation of the interproximal bone level on adjacent teeth is essential in supporting the interdental papilla as well. So in a case like this, where we know we have the impending loss of 2 lateral incisors, it's important for us to recognize that what is the interproximal bone level like. This is going to aid in whether or not we feel that there's some predictability in regards to our soft tissue success. So looking at this case, the teeth are removed and we replace with implants. And as we can see, in a situation like this, we're able to preserve the interproximal bone, which allows us to preserve the interproximal tissue, and we get a beautiful aesthetic result. Key points to remember, as described by Dr. Tarnow, for predicting the papilla growth between adjacent teeth. In his classic study was between natural teeth, but we learned that the 5mm rule also applied and is valid for implants adjacent to natural teeth. And if you remember, the 5mm rule states that when measuring from contact point of the restoration to the crest of the bone, the papilla will fill the space if the measurement was 5 millimeters. You get 100% of the time you will fill that space. 6 millimeters, 55% of that time, and so on. So we know that the predictability of our interproximal tissue is dependent on the bone that remains. To ensure the most predictable outcome, the following must be properly orchestrated and completed. Obviously, like any other restorative treatment that we would be considering, proper treatment planning is key. You also need surgical techniques to reduce the loss of hard and soft tissue. The placement of a proper flat emergence profile healing cap or the custom fabricated healing abutment is also very important to prevent tissue pressure or to prevent tissue collapse. Provisionalization is also important. It requires the proper emergence profile and interproximal contour to guide the soft tissue and help support it and grow in the directions that we need it to grow. And then finally, we need fabrication of a definitive restoration that's going to mimic all that we achieved with the soft tissue during the provisional stage. Minimizing the duration of treatment and preservation of soft and hard tissue structures should be the goal. Customized provisional restorations with sound surgical procedures will provide a mechanism by which preservation of hard and soft tissue can be achieved. So studies have shown, and we know this, that the immediate implant placement helps to preserve the alveolar height and width and reduces tissue loss following the extraction. Now, some think the purpose of a dental implant is to replace the tooth, and rightly so. It is one of the important things, but of equal importance is preservation and support of the soft tissue, because without the natural soft tissue contours, it would be very difficult to achieve natural aesthetics. Utilization of a customized provisional abutment and immediate provisionalization allows us the maintenance and guidance of gingival and alveolar structures. So the advantages of immediate custom provisionals and immediate provisionalization are they provide optimal aesthetics during the healing phase. It also helps to eliminate the need for a removable provisional during that time and has the ability to guide tissue during the entire healing phase. So it gives us the ability to begin to guide tissue and push tissue in directions that we want it to go to help close and create natural contours between a tooth. Additional benefits of the immediate provisional is that it reduces chair time. It eliminates the additional need for stage 2 surgeries, and then again allows us the ability to preserve and guide the soft tissue and have an immediate aesthetic outcome. Maintaining the hard and soft tissue is critical to achieving predictable aesthetic final restorations, because without the provisional, the surgery done properly, implant placement where it needs to be, preservation of the hard and soft tissues, and the guidance with the provisional, predictable final aesthetics would not be possible. For optimal results, the provisional should be placed immediately following surgery or within 24 to 72 hours. And the reason we do this is to try to avoid a disruption of the integration of the implant substructure itself. There are two immediate provisional options available to us. The first one is the laboratory fabricated provisional, which we're all familiar with. That can be done either with computer-guided fabrication or done traditionally ahead of time with in a laboratory with stone models and lab components. Our second option is custom fabrication by the clinician chairside at the time of surgery. And our two options here are direct fabrication, or what I call a combination direct-indirect fabrication with stone models. Prefabricated or laboratory fabricated provisionals have some advantages and disadvantages. The advantages of a laboratory fabricated provisional is it's highly aesthetic. So what the lab can produce for us using lab processed provisional material can create a highly aesthetic, and we've all seen these provisional created by the laboratory. One of the other advantages is the doctor does not have to provide any provisional implant components chairside at the time of surgery, and there's minimal skill required in order to place a laboratory fabricated provisional. Some of the disadvantages, however, are that the provisional may not address the exact tissue requirements that present themselves during the surgery. And computer-generated or provisionals fabricated ahead of time with laboratory stone models also do not represent the exact situation that can present chairside at the time of surgery. So you're sort of locked into a situation that may not be the case at hand. Provisionals may require a significant amount of customization. You've seen this where we've done prefabricated temporaries on whether it be a full arch reconstruction, and the temporary comes in and you try to fit it on your preparations, and many times those provisionals require significant modification just to get them to seat. That also can happen when a temporary is fabricated ahead of time. And then there's the additional lab expense for the fabrication of the provisional by the lab technician. The custom fabricated provisional, on the other hand, has advantages and disadvantages as well. The advantages are that it captures the situation as it presents surgically, and it has the added flexibility of addressing the tissue as it presents. So chairside, you're able to make a decision and modify the contours of that provisional very easy at the time of surgery. It allows for immediate guidance of the tissue from the moment it is placed, and there's no additional lab expense that's provided when you're fabricating the temporary chairside. The disadvantages, however, are that it requires the use and knowledge of implant provisional components and the skill to fabricate and place an implant provisional. So we often ask, well, where do we start? Well, naturally, with all restorative situations, we would start with a diagnostic phase. The position of the implant must be predetermined with the information derived from the diagnostic phase. The information that we have to have would be just like any other restorative situation. We need study models, we need radiographic findings, and we need clinical findings in order for us to come up with a treatment plan and discuss the situation with both our patient and our surgeon so that we can predictably work towards ideal results. Once this information is gathered, a diagnostic wax-up can be created to aid in the fabrication of, one, the surgical guide, which we're going to need to share with the surgeon so that he knows where it is that we'd like to place the implant. And we can also then make a provisional matrix from that wax-up that we can use later chairside in the fabrication of the provisional. The surgical template is used at the time of surgery to guide the placement and position, and the provisional matrix is used to fabricate the provisional. The principal benefit of an immediate custom provisional is that it duplicates the emergence profile of the extracted tooth at the time of surgery. If the surgeon is skilled and is able to extract the tooth with minimal disruption to the osseous tissue and soft tissue in the area, the beauty is that emergence profile of that extracted tooth is preserved and allows us and gives us the ability to create a provisional based simply by following the contours that remain from the natural tooth. It allows us to support the gingival form and maintain soft tissue contours and guides the tissue during healing. The immediate custom provisional technique also addresses the placement of the restorative margin, because one of the most difficult things is that you may arbitrarily take an impression or fabricate a provisional, but until you can communicate with the dental ceramist, dental laboratory, where that margin is relative to the soft tissue. We've all seen where the crown and the abutment come back and the edge of the abutment may show because the crown does not go subgingival enough. So the custom provisional allows us, chairside, to take control of this situation and create the provisional margin early on the procedure and have a predictable end result. The clinician creates the restorative margin position at the time of surgery, ensuring a predictable tissue position for the final restoration. So in a case just like this one, by predetermining where the margin is going to be, and we know that that's going to be subgingival, when we place the provisional and then the final restoration, we know that all of that is going to be in a position that we predetermine. The role of the implant provisional is to mold the tissue, not just simply replace the tooth. So when we're going to provisionalize, we're going to use the provisional as our first level or first guide to what those aesthetics would be and to help guide the tissue to the positions that we want it to be as well. No matter how good the surgeon is, it's still up to the restorative dentist to mold the soft tissue. They can give us the bone grafting and they can create the osseous architecture, and they can hopefully give us the soft tissue grafting to create a bulk of tissue that we can work with. But the final contours are going to be up to the restorative dentist. So in a situation like this where we have our surgeon has done a wonderful job of providing us what we need as a basis, we're still going to need to go in and shape the tissue, whether it be with a laser or an electrosurge, and sculpt the tissue to start to create the subgingival contours that we need for the proper emergence of that provisional. So without doing this, there would be no way for us to have a predictable end result. We can create the provisional abutment, allow the tissues to be guided to the positions we want. We can create the restorative margin where we need it, and then communicate these findings to the laboratory. So in the end result, we end up with a very nice soft tissue emergence and a beautiful restoration that blends into the natural dentition in a way that can't be distinguished from an implant or a natural tooth. The customized provisional technique is utilized in primary two clinical scenarios. The first one is after traditional healing time, which is the first case that we have depicted here. And the second one is immediately following surgical placement of the implant, which is our second case. There are two techniques for the fabrication of the custom implant provisional, and the two techniques, as we talked about initially, was the direct fabrication, or what I call the combined direct-indirect fabrication with stone models. Some of the other things that we need to understand before we're able to create a provisional is we need to understand some of what those contours need to be. So we need to understand how the contour of the provisional is going to influence the gingival form and shape of the tissue. So I have three examples here of three different shaped provisionals. The first one I'm going to call tapered. The one in between is going to be a medium taper, and the one on the right is going to be the broad taper. And each one of these is going to have a different influence on the soft tissue and the guidance as it's healing and the direction that we want to move or influence that tissue to go or grow. I'm going to go ahead and take them sort of individually. The interproximal contour influences the soft tissue position for single tooth implants adjacent to natural teeth. So let's look at the tapered one. And if we have a tapered situation, the tapered has the least amount of influence on the interproximal papilla. And you can sort of understand this. If we had papilla in between and around this provisional, it's so flat that it would not allow support and give any dimension to help hold the soft tissue in place, and usually we'd end up with a flat contour and blunted papilla. The second situation is the medium tapered. Now here what we've done is we've begun to expand the neck of the provisional. And again, in your mind's eye, you could see if you use this in a situation where we have some thick tissue or a thick biotype, in that situation, this may be adequate to hold and support and push and guide the soft tissue in a position that we need to. Now many times this is all we need, is a medium tapered provisional to do the job. But there are times where something a little more broad is needed, and that's what we're going to call our final one, is the broad tapered. And in this situation, the broad tapered is useful with thick or thin biotypes because it allows a wide contour that helps push or guide the tissue interproximally and help to squeeze the papilla from below to create support for those papilla to help close the triangle. The only caution, though, as you get more broad in your provisional is that you do need to understand that if you excessively over-contour, then the tooth becomes more and more square in its presentation, and you actually can get to a point where you squeeze the papilla to such an extent that you inhibit the growth of the papilla into that space. So this illustration is going to be just sort of a general illustration of how each one of these may be used in a situation. If we take the tapered and place it, notice how this is too much of a taper. It does not give enough support and guidance to the soft tissue, so we end up with a triangle, open triangles here. If we use a medium taper in a situation like this, we might end up with a better situation. Again, that widening of the base and widening of the contour helps to support the interproximal tissue and guide the papilla. But there's still some space. And then in a situation where we take our broadest one, and sure enough, this one works in such a way that by broadening and expanding the gingival contour of the provisional, we can actually squeeze and mold and push the soft tissue, the interproximal papilla, where we'd like it to be. And as you can see, the contour is the contour is created not high up towards the contact, but down low subgingivally to help support and raise that tissue. Another aspect of the provisional that we need to take into consideration is the facial prominence, or how flat or broad the facial aspect of the provisional is as well. Because the facial aspect is what's going to help influence and alter the soft tissue scallop. And you can see in a situation like this, if we have three different types of provisionals, a flat emergence profile is going to give very little support to the facial free gingival margin. Now, in some cases, that's exactly what we may need, where if the soft tissue scallop is already in concert with the adjacent tooth, we wouldn't want to influence it or push it anywhere else. So a flat contour may be just what we need to keep that soft tissue margin right where it is. But if there's a case where you want to actually try to move the soft tissue contour either gingivally or incisively, you would need to consider one of the other forms of facial contour. So to just review, the flat contour would allow you to help move the tissue more coronally, and the broad one, as you widen and broaden the facial contour, actually allows you to move the scallop either gingivally or apically, depending upon how broad you make that the contour of that provisional. And here's an example of what I was trying to illustrate there. What we have is we have a situation where the papilla have not grown into the space. We have good adequate soft tissue here of a thick biotype, and it actually does need to be pushed or guided to a position to help support it and then close those triangles. So in a situation like this, we're using a broad taper on our provisional interproximally to help push and support the papilla from below. And we're also using a little bit broad facial profile, because if you notice the gingival levels of tooth number 8 and 9 are not exactly even. So by using a little broader facial taper, will hopefully allow that scallop to migrate a little gingivally, and during the final restoration we'll end up with two even gingival contours. The main issue here is creating the illusion, and again, like this artist has created the illusion of something that's just not real by painting a street. With the provisional, we need to create the illusion, and ultimately with the implant create the illusion of a natural tooth and the natural soft and hard tissue architecture.